Yeah, so after our last session, went back, looked through a lot of the content, and I think I'm just going to try to keep it high yield. So probably we're not going to go for the full 2 hours today. May sort of depending on how much we have to cover and how fast the questions go, which I don't have too many today. It's like most of the content. We might actually finish in an hour, maybe an hour and some change, just sort of depending. So why don't we get started with, I'll address a couple of questions for you guys in terms of like the stuff that was asked the last time. So a couple of things that came up during our last session. I think that the first thing that I looked into was what is the utility of testing for an ACE level. And so I think overall, looking at the test characteristics, when you're talking about sarcoidosis, the utility of ACE level testing is not very good. So the source that I found basically said that it's only about 75% sensitive. So that means 25% of people with sarcoid do not have an elevated serum ACE level. And it's also has like poor specificity. So, about 10% of people that have an elevated ACE level, it's not elevated for any particular reason. So, I think the bottom line is there's a lot of false negatives and false positives with this test, which is unfortunately why really the best and the only way to do testing for sarcoid is ultimately with a tissue biopsy. Typically, you're going to go for one of the lymph nodes to find the granulomas. That was the first thing. The second question that I ended up looking into was the usage of therapeutic alpha-1 antitrypsin, because I think that came up in one of our prior questions. And bottom line is there's really nothing, I think, for an internist to know as far as that's concerned. The data that I was able to find actually looked at specifically alpha-1 antitrypsin deficiency, and it was infused alpha-1 antitrypsin in like very carefully selected patients. So outside of that, I don't know that alpha-1 antitrypsin has a well-defined role. It seems like it's kind of like an investigational therapy. And finally, we talked a little bit about using antibiotic suppression in cystic fibrosis. So let me go back to my CF. Where's the cystic fibrosis? I don't know. I mean, I feel like, oh, you know what? That's actually back in the asthma section. That's when that question came up. Okay, here. So the question came up at one point in terms of what is the role of using antibiotics in cystic fibrosis? And so I don't think it's really clear in terms of what exactly, like why do cystic fibrotic patients derive benefit from oral azithromycin. From the source that I read, it seemed like it was anti-inflammatory, but I don't really know that there's strong data for that. So as far as I'm concerned, any antibiotics and the usage of cystic fibrosis are about bacterial decolonization, less so in regards to any kind of anti-inflammatory measure. So why don't we go back down? So last time I showed you guys a bunch of pictures. We talked about a bunch of different interstitial lung diseases. Let's see, we talked about pulmonary alveolar proteinosis and how you don't really need to know anything about it. And now we're up to silicosis. So this is going to be our last foray into interstitial lung diseases. So in terms of silicosis and other pneumoconioses, there's really not anything special that you guys need to know about them. Obviously, once the patient is diagnosed with, like, people need to use appropriate PPE, but once somebody is diagnosed ultimately with pneumoconiosis, you really need to make sure that they're removed from the exposure. And silicosis, but probably the other players as well, have an increased risk for tuberculosis as well as lung cancer. And obviously, once the damage is done, it's done. This is all scar tissue. There's no treatment there. I think I may have showed you guys a couple of pictures of pleural plaques. So this is asbestosis, right? This is what you might see on an X-ray in a person that has calcified pleural plaques. And this is what you might see on the CAT scan, right? So on the axial view, you see that on the edge, you've got some ribs. And then right adjacent to that, you've got this pleural thickening, and in this patient, it's actually very dense and nice and beautifully calcified. I think a common, well, I don't know how common it is. I don't treat that many patients with asbestos, but I think a clinical problem that we encounter with asbestos is what do you do when you get a patient with these plaques, right? I mean, we know that they have this elevated risk of mesothelioma from all of the commercials that we grew up with. So how do you approach these patients? And I think the bottom line is the way that you manage this is generally clinical. So I think if you identify a person who has asbestosis or pleural plaques, you don't really, there's nothing special that you need to do about that. And I'll double check because this is kind of like outside of the scope of my practice. But it's not like there's no really hard and fast recommendations for like a routine cancer screening. Obviously, if they've got fever, like chronic fevers, weight loss, if they look like they have cancer, you really got to get in there. But routinely, I mean, it's going to be really difficult to identify cancerous plaque here because what are you going to biopsy? Are you going to biopsy this little area up here? Well, what about the rest of the plaque on the contralateral lung, right? So because you can't biopsy everything, there's not really a role for kind of routine invasive testing to identify patients that have malignant pleural plaques. I think you just manage them clinically. We will talk about pleural disease in a little while. That's why I kind of put asbestosis last, because it's going to be a good segue into speaking about pleural-based disease. And we'll sort of talk about the general approach to how you would kind of think about these patients. But for the most part, when you've got a person with pleural plaque, you just watch them until they start developing anything that's suspicious of malignancy, and then you kind of move forward through the diagnostic process, and we'll go through that in a little bit. So these are like sort of the big exposures, right? Any blue collar construction mining type job. Big complications, we talked about the pleural plaques. Exudative pleural effusions are also a relatively common thing. And then, of course, interstitial lung disease is the really big player when it comes to asbestos exposure. Like I mentioned before, mesothelioma is probably almost exclusive to people who have been exposed to asbestos, but the most common lung cancer in people who have asbestos exposure is still just good old squamous cell carcinoma. The interesting thing is that when you have asbestos exposure, that raises your cancer risk. And obviously, when you've got smoking, that raises your cancer risk too. But when you have both, it's actually a multiplicative risk. So while with either one, your risk of cancer might go up like 5 times, when you have both, it goes up 50 times. So obviously, all patients should be tested for asbestos. Okay, so that's really it for asbestos. Again, really not much to do about it aside from prevention. Okay, let's talk about pneumothoraces. So I'm going to leave this question up. I'm going to give you guys a minute to digest it, and then we're going to go through how you would think about this person and some of the guidelines here. Okay, wonderful. Thank you guys so much. I really appreciate you guys volunteering to work with me through these. So I'll go through this one. I know, like doing like CME and board certification is like the worst, but hey, we all have to do it, right? Okay, so let's go through this together. So there's a couple of key things in terms of addressing pneumothorax. And again, this is like, again, also outside of my specialty. I don't normally address pneumothoraces either. The only reason I know about it is because I've been pigeonholed into teaching it over the last couple of years. But this is really an emergency medicine / critical care kind of thing, although presumably it might appear in boards. So let's talk about some basic treatment tenets of how to approach this, and then we're going to actually come back to the question. We'll do it together. So what we're talking about right now is people who have spontaneous pneumothoraces, like this patient, the young kid, the young kid that we heard about just now. So if you are looking at a secondary, or not a secondary pneumothorax, like an iatrogenic pneumothorax, that's a completely different ballgame. I think that's if we cause a pneumothorax, then the management is going to be relatively straightforward. But there's a special way to think about it when it's spontaneous, and that's what I'm going to address. So number one, when somebody gets a pneumothorax, like a couple of you guys mentioned, supplemental oxygen is like standard of care, right? So you're going to want to give everybody high flow oxygen. I have to admit, I have tried to ask so many pulmonologists why we do this, and no one has ever been able to answer the question for me. Apparently, it helps the pneumothorax get reabsorbed, but I have no idea what the pathophysiology is, despite trying to look it up multiple times. So at the first junction point, you have to decide, is this person with a pneumothorax, do they have good lungs? Or let's see, I just want to mention, so the resorption is better as oxygen and nitrogen exchange is faster. I'm gonna have to read about that. That sounds good, but I don't feel it as well as you do. So the first thing you want to do when you're addressing pneumothorax is identify, is this primary or secondary? In other words, do they have good lungs or do they have bad lungs? The question of good lungs versus bad lungs tells you a number of things. So first of all, it tells you what are the chances that they have a very large defect in their lung. So if somebody has good lungs and they get a pneumothorax, they're probably likely to have a very small defect, and that thing might actually close on its own. If they've got lung disease, if they've got crappy lungs, they have COPD, interstitial lung disease, then their defect from the pneumothorax is likely large. And when it's a large defect, when it's a big hole, it's unlikely to close on its own. So that's the first way to conceptualize these patients. Once you conceptualize it, now we can kind of get into therapy. So the pneumothoraces are stratified into small versus large. So small means less than 2 centimeter difference between the actual lung and the chest wall. So when it's a small pneumothorax, in either circumstance, regardless of what caused it, it's fine to observe it, right? So you can just put them on oxygen and watch them, and hopefully it doesn't get worse. Now, obviously, people that have healthy lungs, they're more likely to have small pneumothoraces. People that have bad lungs, they're less likely to have initially small pneumothoraces, again, because their defect is likely to be fairly large. Now, the junction point separates once you get into large pneumothoraces. Because people who have healthy lungs are likely to have smaller defects, you actually can start with them with a simple needle decompression. And I'm not even talking about tension pneumothoraces right now. I'm talking about a non-tension, sort of simple, large pneumothorax. For good lungs, you could just do a needle decompression on them because it's likely that the hole is relatively small and might seal up on its own. So you do a needle decompression and then watch them. Obviously, if their pneumothorax re-expands, then they're going to need a chest tube. They kind of de facto have a larger defect at baseline. In somebody that has COPD, you don't bother with the needle decompression first because they usually don't even come in with small pneumothoraces, and because they have these large defects, so you would just put a chest tube in them straight away. So there's no point in bothering with needle decompression. They're likely to need a couple of days with a chest tube to allow that hole to heal. The second junction point between bad lungs and good lungs is, what do I do to prevent this long term, right? So as you might imagine, if you've got a young person that's otherwise healthy, they don't have any medical issues, maybe it's going to be a once in a lifetime type thing. So you don't necessarily pleurodece a young person with a first time pneumothorax who doesn't have any lung problems. maybe, I don't know, maybe they have a temporary issue and it's going to go away. If they have recurrent pneumothoraces, then maybe they have some sort of like Ehlers-Danlos or Marfan's or one of these connective tissue genetic syndromes that increase their risk of having recurrent pneumothoraces. So if you've got a young person who has healthy lungs, but they're coming in with more than one pneumothorax, they're clearly prone to it, you're going to have to chlorodese them. Contrast this to somebody that's got crappy lungs. If they come in with a pneumothorax, then they probably just need to be chlorodesed then and there. And the reason that you do that is, again, they're likely to have this reoccur in the future. So it's really all about risk stratifying these patients and thinking, is this a small hole or a big hole? And how likely is it to recur in the future? And that's how you kind of diverge in terms of treating these patients. Obviously, with a tension pneumothorax, you're going to need to decompress them immediately, right? Because they're going to they're going to become unstable and go into shock. They're going to need a chest tube because they have a one-way valve that's causing that pneumothorax. And in terms of long-term management, sort of, I think, is the same principles that we talked about earlier, depending on what is their risk of recurrence, depending on do they have healthy lungs or do they have shitty lungs. In terms of being adventurous, they can't go on a plane until the pneumothorax is completely resolved because of the changes in barometric pressure, right? You go up to altitude, you've got large changes in barometric pressure, you are going to impact your intrapleural pressure, and obviously, so you don't want to go onto a plane even with a small pneumothorax. Bad idea. Once it resolves, once it heals, sure, you can fly. It's not really that big of a deal. In terms of diving, scuba diving is a special situation. I know, we probably don't take care of a lot of scuba divers. I have never met one in my life, or maybe I met one and I just didn't ask them, I'm a bad doctor. But the bottom line is, because there's very, very large barometric pressure changes in scuba diving, and when somebody goes scuba diving, especially at in deep waters, they're basically getting like sort of positive pressure ventilation, right? They can't do that if they get a pneumothorax. You have to do a chlorodesis on them before they're cleared to go back to diving. And again, it's all about barometric pressure changes and the forces that are put on their pleura. Obviously, all these patients should stop smoking. I probably just need to take that out of my slides because, all right. So now that we've sort of gone through that, let's talk about sort of the salient points in this case. So remember, the big things we're going to focus on here is this a primary pneumothorax? Does he have healthy lungs? Or a secondary pneumothorax? Does he have sick lungs? The second thing we're going to focus on is the fact that he's a scuba diver, which, I mean, I don't know, they wouldn't normally throw you a curveball like this, but that ends up being relevant to this question. So he's a 25-year-old guy. Yes, he's a smoker, but it's 8 pack years only, and it says that he does not have lung disease. There's a chest radiograph that's showing you that he's got a large pneumothorax, but he has no signs of attention, and they don't mention anything about they don't mention anything about him having known lung disease. So how are you going to manage this guy? So remember, first point is it small or is it large? So because they're saying that he's got a large pneumothorax, you should not observe him. You probably need to actually do something about him. So with a large pneumothorax, you're probably going to first do a needle aspiration on this guy. And once you take the needle out, hopefully he reabsorbs. If he doesn't reabsorb, then you're going to need to do a chest tube until he finally does reabsorb. Now they're saying, what do you do in terms of additional pneumothorax management? So the critical thing here is he's a scuba diver. Because he's going to want to go back to scuba diving, that's the reason why you would probably chlorodese him later on. If that sentence was absent, he wouldn't need a chlorodesis. This is a initial episode of a primary spontaneous pneumothorax. So you'd probably put a needle in him, drain the pneumothorax out, and then watch him until he got better, and then he could go home and be on his happy way, right? So for those reasons, you're not going to observe him as too large. Needle aspiration is like the most, it's like the immediate next step. But the best answer is actually A, because it's got catheter thoracostomy, right? same thing as a needle. And then once it's resolved, you're actually just going to pleura descend once you get the pleura opposed. This is a really challenging question. So I appreciate you guys going on a limb here. I think I got this wrong myself when I did it at first because I missed the scuba diving thing. But I wonder if I would have even remembered, if it was outside of the board review. So thank you guys for being good sports. I really appreciate all of you. Okay, so that's it. I don't really know how much pneumothorax is going to appear on the boards, but it is within the realm of critical care, and it's just not covered in the mixed-up chapter of critical care. So I wanted to make sure that you guys got some exposure to it with me before we moved on. Okay, great. So let's get to the good part. So the rest of today, I'm going to be talking to you about pulmonary hypertension, and then we're going to go over pleural effusions. These are two of my favorite topics because I think that I think that with pleural effusions, a lot of my residents struggle, and in pulmonary hypertension, I think many internists also struggle with some of the decision making because I feel like the cardiologists and pulmonologists just hold on to this really tight. So my goal is to try to boil it down for you into like a really easy way to digest. Yeah. All right. So first off, how do I diagnose pulmonary hypertension? The way you do that is easy. It's just by echocardiogram. That's going to get you the diagnosis like 100% of the time. Okay, all the time you will get a diagnosis by pulmonary hypertension. These are normal right ventricular systolic pressures. In terms of what's abnormal, anything PA pressure over 25. Typically, 25 to 35 is considered mild. 35 to 50-ish is considered moderate, and then 50 to 60 to 70 is considered to be like severe-ish pulmonary hypertension. I would consider it severe when they get symptoms. So ideally, your patient should be asymptomatic. Let's talk about how we group these things. So I know there's the group numbers. I would encourage you guys not to bother with the stupid group numbers. Just remember the fundamental pathophys, because the underlying pathophysiology is ultimately going to be how you what testing you do for these people and how you ultimately manage them. So I have the three sort of more common ones at the top, right? So group 2 is heart disease, right? Anything that impacts the left heart is going to raise your pulmonary artery pressure due to backup pressures from the left side. So any heart failure, any valvular disease, even systemic hypertension, which arguably is a very uncommon cause of pulmonary hypertension, but systemic hypertension, if it's bad enough or if it's long-standing enough, can increase your pulmonary artery pressure. And so in circumstances like that, you might actually consider treating their systemic hypertension first before you start getting into the pulmonary hypertension aspect of it. So systemic hypertension is actually just group 2 / heart disease type of pulmonary hypertension. Group 3 is because of hypoxia, from lung disease. So I think earlier we talked about how there is pulmonary arterial or vasoconstriction in response to hypoxia. That's how your lungs match the ventilation with the perfusion, right? You have a person who has some emphysema, some other lung segments are not ventilated. When they're not ventilated, they become hypoxic, and your body's like, oh, let me not perfuse them because that's basically dead space, right? So because of that mechanism, if you've got a lot of that crappy lung, if you've got a lot of hypoxia, well, that's just going to raise the resistance of your total pulmonary arteriolar circuit. So naturally, just like with heart disease, it's going to focus on treating the left heart and the hypertension. With lung disease, it's going to focus on addressing those things. And in these patients, supplemental oxygen also can benefit them if they are actually hypoxic. Group 4 is chronic clots. We're going to talk about that. I love CTEPH. I actually, it's weird. I went 10 years without ever meeting a CTEPH patient. And then 3 weeks ago, I got 4 of them all in 1 week. So I don't know where they were, but finally they came to me. I was excited to talk to all of them. So we'll talk about CTEPH in sort of a separate context. Then there's group 1 and group 5. And group 1 and group 5 are just a bag of trash. So group 1 is people who have problems specifically with their pulmonary arterioles being tight. we don't really know why that happens, but the bottom line is that we give these people some kind of vasodilator to address that. And then unfortunately, group 5, there is no treatment because we don't even know what the pathophys is, so there's no therapy for them. I would argue that if you find somebody that has an unknown pathophys, they're probably going to be trialed on a pulmonary hypertension drug, even though we understand that pulmonary hypertension drugs don't work on them. Because, I mean, what else can you offer them, right? Like a heart and lung transplant? It's kind of a shitty thing. So let's see. I don't want to go in through the different pathways by which all of these like random garbage bag things cause pulmonary hypertension. Just understand the final common pathway ends up being their pulmonary arterioles. Because it's kind of different for all of these syndromes, how they cause it exactly, and none of us really need to know that. That's like a pulmonologist job. It's a researcher's job, not even a pulmonologist job. So the one thing that I do want to emphasize with you guys a little bit, just because I find it so fascinating, is pulmonary veno-occlusive disease. And I'm going to compare and contrast pulmonary veno-occlusion with group 4 with clots, because they kind of sound similar, right? Pulmonary veno-occlusion, thromboembolic pulmonary hypertension, like, are those not the same thing? So I want to talk about both of those things, and we'll cover that in a second. So what are the tools that we use in terms of managing, like determining how to manage pulmonary hypertension, diagnosing it, working it up, is going to be your right heart catheterization. And I'm going to talk to you about what is the role of right heart cath, what questions does it answer for you, when is it actually useful. So I have this very simple illustration, right? This is your right ventricle leading into your pulmonary artery, right? These are now your pulmonary arterioles. This is blue because this is all deoxygenated blood. This ends up being your pulmonary capillary bed in your lungs. These are your pulmonary veins, which are now red because they're oxygenated. And these go into the left atrium, right? So one of the tools that we use with, sorry, I'm losing my mind. Didn't get enough sleep last night. So with right heart cath, the big thing that we're going to measure is going to be your pulmonary capillary wedge pressure. The reason you're doing that is because when you get a pressure that is wedged into the capillary bed, that's going to be very closely reflective of what's going on the left side of the heart. And it's like not nice to do a left heart cath just to get like a left atrial pressure. Like that makes no sense. It's a little bit too invasive to do an arterial puncture and then stick around in there and maybe give them like a coronary dissection, like, poor form. So we can get a nice surrogate marker by using pulmonary wedge for that purpose. Now, what's the difference between, we mentioned this a little while ago, what's the difference between chronic thromboembolic pulmonary hypertension and PVOD, pulmonary veno-occlusive disease? The difference is in the location of the problem, right? So with chronic thromboembolic pulmonary hypertension, these are just regular old pulmonary emboli. These are clots, right? And these clots sit in the venous side of the circuit. So they sit in the pulmonary artery, and they're usually here, right? So in this situation, in theory, your pulmonary capillary wedge pressure should not be affected because the clot sits like somewhere proximal here, and then you wedge all the way into the capillary. So it actually should not affect the capillary or the left atrial pressure, which is what the pulmonary capillary wedge is meant to measure. By contrast, with pulmonary veno-occlusive disease, you actually get, it's like a weird thing. We don't really understand why it happens or what the pathophysiology is. There's not really great therapy for it as far as I know. But the proliferation actually happens on the sort of post-capillary, on the pulmonary arterial side of the circuit. And this process is more akin to like atherosclerosis rather than clots. So the lumen of their pulmonary veins actually, or the pulmonary venules actually shrinks. And you might think to yourself, oh, well, the wedge is a great tool for identifying this because if I wedge these patients, naturally the pressure is going to be higher because this is like almost like a left heart disease, which is, I think, what was thought for quite a long time. But it turns out that a normal pulmonary capillary wedge pressure does not rule out pulmonary veno-occlusive disease. I don't think anybody's ever going to ask you about this on the boards, but I just thought it was very fascinating that this tool that looks for left heart disease actually won't pick up pulmonary veno-occlusion. Unfortunately, that is one of the reasons that pulmonary venous occlusion is very, very difficult to diagnose, and I have no guidance for you because I've never diagnosed it either. So, we're all in the same boat. We're in this shitty medical field together. All right, let's see. So we talked about right heart catheterizations, and we compared and contrasted thromboembolic pulmonary hypertension to venous occlusion. I just want to take a break for 5 seconds. Does anybody have any questions on what we've talked about so far? Okay, fabulous. Like I said, guys, feel free to interrupt me anytime. I'm here for you. I love doing this stuff, so please, always happy to talk. Okay, so we talked earlier about how to diagnose pulmonary hypertension, and echocardiogram is like the way you're going to diagnose it literally every time. I know I wrote here that it's not 100% sensitive, but it's pretty goddamn close, right? Now, a couple of things that you need to know about echocardiograms. So the first thing is the way that they diagnose pulmonary hypertension on the echocardiogram is by measuring the velocity of tricuspid regurgitation that the patient has. So there's 2 limitations to this method, or I guess 3 limitations. So the first limitation is if they have no tricuspid regurgitation, or if it's just trace, you won't be able to measure the pressure. Second limitation is if they have like wide open tricuspid regurgitation, that also may make it difficult. And then finally, if the person has like just a really large body habitus, or they have got a poor echocardiogram window, you may not even see the tricuspid valve. So in these circumstances, you may not be able to effectively rule out pulmonary hypertension. So my advice to you is, under most circumstances, you're going to be able to identify pulmonary hypertension just by looking at the echo. You'll get a decent window. They'll say, there's a little bit of tricuspid regurgitation, but overall, there's nothing suspicious for pulmonary hypertension, and you'll be done with it. However, in a minority of cases, you may have a patient that's coming to you with chronic progressive shortness of breath, and you looked at their lungs, and their lungs are fine, and you looked at their heart, and their heart's fine, and did an echo, and they're like, no tricuspid regurg, but we couldn't really measure the right ventricular systolic pressure. So if you can't get a reasonable right ventricular systolic pressure in a patient for whom you have a high index of suspicion, just understand that echo is not the best test. It's just the easiest, okay? So, and it is quite a good test still. So on that fringe circumstance that you're working with a patient who you don't know why they're short of breath, but they clearly don't feel good, they've got poor exercise capacity, and you've done your due diligence with all the other stuff and you have no idea what's wrong with them, one thing you might want to consider is, should this person get a right heart cath? Because a right heart cath is really the gold standard if you want to diagnose this disease and you haven't been able to diagnose it otherwise by echo. This is a conversation that you probably would want to have with either a cardiologist or a pulmonologist. I mean, I wouldn't just send them for a right heart cath, but I guess if you're going to send them for a right heart cath, you'd send them to like one of these people, right? So it probably makes sense if it's like one of these fringe situations to pick up the phone, call the cardiologist, say, hey, I'm not really sure what's going on here. Do you think this person may benefit from a right heart cath for the purposes of diagnosing pulmonary hypertension? It's a very uncommon thing to do. Like I said, echo is always going to be the way that you diagnose this disease, but you've got right heart cath in your back pocket if you need to. Let's see. So that's the first reason why you might want to do a right heart cath. The second reason why you might want to do a right heart cath is for what's called vasoreactivity testing. So actually, no, sorry. Let me, I'm going to come back to vasoreactivity testing in a second. Let me talk about the wedge. So the first reason, so there's only 3 reasons why you would ever do a right heart cath, all right? At least the only ones that I've ever encountered. So number 1 is the one I just told you about, right? It's like, if you think they might have pulmonary hypertension and you actually think the echocardiogram is wrong, with the understanding that the echo is almost never wrong, but sometimes it is. The second reason is to measure a wedge. Now, a wedge is very helpful for you, right? So let's say that you've got a patient with both, like they're a long-time smoker, and because of their smoking, they've been on the naughty list for a while. They now have COPD and also have had a bunch of heart attacks and have left heart failure. And they have got pulmonary hypertension on the echo. Well, you might want to figure out which one is it from. I mean, is it from COPD, and do we need to focus on optimizing that? or is it really a left heart failure issue, or is it something else, right? And so pulmonary capillary wedge pressure is really good at telling you, is the pulmonary hypertension they have right now, is at least a component of it secondary to their left heart disease. If somebody doesn't have any left heart disease, I don't really know that measuring a wedge is going to be super helpful in them. I mean, it could be. You might identify some, previously non-identified left heart disease, but honestly, like I said, echo is really the boss here. So this is the other thing that right heart cath can help you differentiate between: is a pulmonary hypertension from left heart disease, or is it from something else? So that's the second question that it can help you answer, obviously, in select patients. Very, very important is, if you are going to do a right heart cath for this purpose, you want to make sure that the person is in as good condition as they possibly can be before they go for the right heart cath. Because the left atrial pressure, the pulmonary vein pressure, and the wedge pressure, all three of these things that are related, all go up when a person is decompensating and when they're volume overloaded. And if you get a right heart cath and find a high wedge in a patient who's currently volume overloaded, it's not helpful information. Was their wedge high just because they were volume overloaded? Well, okay, well, maybe I'm going to diurese them now, but you don't want to subject them to like two different right heart caths. So the goal is optimize them as much as possible first, diurese the shit out of them, get them really dry. And then if there's still a question, yeah, you send them for the right heart cath, and then you can identify in the best shape that they can possibly be in, is it pulmonary hypertension from the left heart disease or not? How are we feeling? Good? Great, okay. Number 3, vasoreactivity testing. So let's say that you've done the work and you've looked for all of the sort of common cause of pulmonary hypertension, and you're sure it's not the lungs, you're sure it's not the heart, and you're sure it's not chronic clots, right? Well, now you're in that garbage bag of, group 1 or group 5 or whatever. So at this point, you don't really know where their pulmonary hypertension is coming from, but you have to decide on how you're going to treat it. You've got a lot of treatment options. We're going to go into those in a little bit, but the main decision point is, should the initial treatment be a calcium channel blocker as a vasodilator, or should we use some more sophisticated, more advanced vasodilator therapy initially? Now, I've never been able to figure out why we don't just empirically put people on calcium channel blockers, but that is not for me to decide. Somebody much smarter than me decided that this is the way we do it. And if anybody has an answer to this, please, by all means, speak up. But the bottom line is, you do this thing called vasoreactivity testing in order to identify, am I going to initially put them on a calcium channel blocker like nifedipine, or am I pretty sure that's not going to work? So why bother with it? Let me get started on something like sildenafil or a more advanced therapy. How does vasoreactivity testing work? It's relatively simple. They do the right heart cath. While they're in there, they infuse nitric oxide into the pulmonary artery, and they measure the pulmonary artery pressure and see, does the pressure go down with the infusion of that vasodilator, with that nitric oxide? If they have an improvement of their pulmonary hypertension in response to the nitric oxide, they're considered to be vasoreactive, and they're likely to respond to calcium channel blockers. If they're not vasoreactive and not responsive to the nitric oxide, they're likely not to be responsive to the calcium channel blocker either. And so your therapy is going to be something else. So, 3 things. There's really only 3 reasons, at least the most common ones, that I can ever think of to do a right heart cath. You really don't ever need a right heart cath, as far as I understand, outside of the context of these 3 situations. First situation is, if you really think that they have pulmonary hypertension and the echo is just lying to you, then you do the right heart cath to confirm. Number 2 is, if you want to measure their pulmonary capillary wedge in a person who has left heart disease, and you're trying to blame the left heart disease as opposed to looking for some other cause of the pulmonary hypertension, because that's going to affect how you think about the patient and how you treat them. And number 3 is for vasoreactivity testing. Once you've identified that they really do have that group 1, that garbage bag of things that doesn't have a pathophys, is their pulmonary arterioles, are they going to be responsive to calcium channel blockers? So there's only 3 reasons. Outside of that, you don't ever really have to do a right heart cath. At least I've never encountered a situation in which we've had to do it in that context. Okay, well, that was a fucking mouthful, huh? Why don't I take a break from talking? We'll do a question. Alrighty, might I ask for a volunteer? Yurdanka, do you mind walking me through your thought process with this dude?
Yeah, it's a patient who is stable hemodynamically, but is overload. And echocardiogram is showing like the RVSP is more than 25, is 60. And with low ejection fraction, then I think we have to diurese the person first.
Right, perfect. Yeah, so this is going to be the immediate next step. Now, there's I put this question together. This is like not a mixed-up question. I painstakingly put this question together specifically to kind of rehash the stuff that we talked about, right? So you're totally right. So the next immediate step, you're going to want to diurese them first. There's a couple other things to consider here, right? So in terms of right heart cath and a vasodilator challenge, you're never going to want to do this before you diurese somebody, right? Because if you're going to go in for a right heart cath, you're going to want to measure the wedge, especially in a person like this who has like obvious left heart disease, and you don't want to do that while they're decompensated. So you're always going to diurese them first. I would even argue this person in general should not get a right heart cath because they look like they have pulmonary hypertension from heart failure. I mean, if you really want to do a good thorough evaluation, of course, I mean, you could do a right heart cath to make sure that their pulmonary hypertension is from heart failure, but it's unlikely to be from anything else, I guess is what I'm trying to say. In terms of some of these other options, we're going to cover them. So sildenafil, you would use if it was like pulmonary arteriolar hypertension, like in that trash bag of diagnoses, and it doesn't look like that's what's going on here, right? This person looks like they have heart failure as their cause. Bosentan, same thing. And then IV dobutamine, I just threw that in there. I said, why not? why not throw in an inotrope? So that may not be a bad answer if you thought this person was in cardiogenic shock, but there's nothing in the question stem right now that suggests that this person needs an inotrope right at this point, right? You're not hearing that they have any organ failure, right? Their brain is fine, their kidneys are okay, and they haven't even been trialed on diuretics yet. I think if we're in the situation where they're on like multiple diuretics and not responding, at that point, maybe we consider a dobutamine trial, but not yet, right? So like Yurdanka mentioned, the goal is to diurese them first, and then we can kind of move forward. Fabulous. Okay, so what do we do in terms of evaluating pulmonary hypertension? So these are all kind of, I think, pretty standard things that I think you can order like as a package for a patient who has pulmonary hypertension. So it makes sense, you know, especially if they've got severe pulmonary hypertension, it makes sense to exclude lung disease. At a minimum, you'd probably want to get an X-ray, but pulmonary function testing or at least spirometry would be really helpful to make sure they don't have like restrictive or obstructive lung disease. You'd want to test them for silent hypoxia. So you might send them for a sleep study with overnight oximetry, because again, if they're hypoxic, that's going to cause it. you're going to want to look for chronic thromboembolic pulmonary hypertension, and you will get a VQ scan on every single one of these patients. I didn't know this for a long time, but apparently VQ scan is a standard routine part of a pulmonary hypertension workup. And we're going to talk about why in a second. You probably want to look for mixed connective tissue disease, check an HIV, and then look for any liver disease. And Sherry, to answer your question, so Sherry asks, are these in a specific order? No, they're not. I think it just sort of depends from your perspective on what's likely going to get me the answer. So if you've got a person that has no overt cause for their pulmonary hypertension, I think I would probably go for the things that are most likely. You know, if they're like obese and they snore, maybe I'm going to start with the polysomnography and the overnight oximetry. If they're a smoker, maybe I'll go for more of the PFTs. If they have a history of clots, I'll probably go for the VQ scan first. But I think in an undifferentiated patient, otherwise, I don't know. I probably would do a couple of them at once. Now, you're not going to get any questions on, you know, what should I do to evaluate the pulmonary hypertension in the absence of something to lead you in a direction. So, but these are all, I think, pretty routine things that we do in the office, and you know, these are standard parts of a pulmonary hypertension workup. So, before we get into more of the fun stuff, let's do another question. Oh, Tom. So to answer your question, Tom, why HIV test? So, it's a common disease. Right. I mean, like the criteria for screening for HIV is like you just have to have a heartbeat, and HIV is a cause of group 1 pulmonary hypertension. So, I mean, if you look at like some of these other things, I'm not going to routinely test people for like schistosomiasis or pulmonary venous occlusion because those are rare, but HIV is common. So HIV does have a pulmonary hypertension association. So that's why I kind of, I would probably include it in the bundle. Sorry guys, I didn't. So Tom asked, why do we do an HIV test? That's what I was answering. Great. So, you guys have had a chance to chew on this for a little bit. So let's talk about this. So, this question is asking you, what do we do in terms of managing a person with CTEP, chronic thromboembolic pulmonary hypertension, once you've kind of identified that he has it with a right heart cath and a pulmonary artery angiography, right? So, why don't we just go directly into it, and then I'm going to come back to the question, and we're going to work through the answer choices in a little bit. Okay, so first thing about CTEP is CTEP most commonly happens in people who first have some sort of venous thromboembolism, right? So they either get a clot in their leg or they get an acute pulmonary embolism. I don't know what people do at your guys' institution, but at Robert Wood in New Brunswick, which is where I work, it's a pretty routine question that our pulmonary docs answer in terms of, do we need to get in there and like do something about the PE? So are we going to maybe do some catheter-directed TPA? Are we going to ask the interventional radiologist to go in there and actually scoop out the clot? And I think my very short and unsatisfying answer to you is that there's not really a lot of data on this question. So even though we tend to like to answer this question a lot, we don't really know whether intervening on an acute PE in any meaningful way actually lowers your risk or not of chronic pulmonary hypertension going forward. We don't know. So that's the first thing to understand, is that we don't really know if it should guide your therapy for an acute pulmonary embolism. Second thing, let me talk briefly about the pathophysiology of CTEPH. So when you're dealing with a patient with CTEPH, they actually no longer have clot in their lung. They did have clot in their lung at some point because it was an acute clot, but at this point, that clot that's in their pulmonary artery has changed. It's no longer all like hematologic clotting factor. It's organized and it's become predominantly scar. And you can actually see this on imaging when you get let's say a CTA in a patient. Often the radiologist is going to be able to comment and say, you know what, this looks more organized, and this is probably a long-standing clot rather than, oh, this thing looks like an acute PE. One thing that is very important to know is that because the clot is made up of different stuff, CTA is actually not very good at looking for it. So in an acute PE, which is, I think, what a lot of you guys are more familiar with, CTA is a test of choice. It's better than VQ scan, not by a huge amount, but by some amount. So CTA is usually your go-to. For chronic PE, because that thing is no longer made of clotting factor, because at this point it's more scar tissue, VQ scan is actually much, much better than CTA. So acute PE, CTA, chronic PE, CTEPH is more VQ. VQ is considered to be like essentially the gold standard, although right heart cath is a little better. VQ scan is almost 100% sensitive for this disease. So that's why I mentioned earlier that a VQ scan is actually a routine part of a pulmonary hypertension evaluation. And you might say, all right, Christopher, but what about somebody that never had clots before? You apparently still do a VQ on them. I don't know why. Maybe they had clots that were silent, and now they have CTEPH as a result of that. So everybody with pulmonary hypertension that's undiagnosed at some point should probably have a VQ scan. It is the gold standard to rule this condition out. Now, what are we doing after we actually identify them? So now we're getting to this question, right? So the really important thing to know about CTEPH is that it's not something that you can fix with blood thinners. CTEPH, so what blood thinners do with CTEPH is they prevent the person from getting potential future clots, but it doesn't do anything for the clots or for the organized scar tissue that's already there. So the only therapy for them that's going to be effective is actually going to be a mechanical thrombendarterectomy. You got to get in there and pull that shit out of their lung. And, you know, unfortunately, this is only done in specialty centers. I don't even know if we do it at Robert Wood, but some people do it. So back to the question, right? So this person has CTEPH, we diagnosed him, and now how do we manage him? So I just told you the answer, right? So it's going to be surgical thrombendarterectomy and evaluation. Let's go through some of the other stuff. So D is obviously out because these people do have to be treated, otherwise their symptoms are going to progress. B, balloon angio evaluation. Balloon angio actually has been looked at in this population. It's not very good. It's not robust like surgical thrombendarterectomy. So really, you just got to scoop that crap out of it. And riociguat is, I think, I don't even remember off the top of my head. I think it's a therapy for pulmonary hypertension for group 1, and we'll get to that in a little bit. So, what else can I tell you about? What else can I tell you about CTEPH? The CTEPH, I think, is very, very important. We talked about diagnosis, we talked about evaluation, we talked about therapy. And then I guess I think overall life advice, because I know some of you guys do primary care, and so I think this is really important to consider. So what you should expect is when a person has an acute PE, and this is what I counsel all my patients on, because I take care of them on the inpatient side and then never see them again. Hopefully it's because they don't come back to the hospital and don't die, but who knows? But what I counsel them on is after an acute PE, people should have 100% recovery, right? I mean, you're expecting that clot is going to go away completely. So usually the sort of way that CTEP presents is they get better in the short term. You know, they go home for a week, they feel like they're recovering, and then either they like plateau and they never really get back to normal, or they get better and then they get worse over time. And it's usually insidious. It's like 3 months, 6 months after the PE, they're getting more short of breath. They have reduced exercise capacity. In a person that is presenting like that, you really just be mindful of CTEP, because it can be difficult to diagnose, especially because a lot of people are they're not knowledgeable that BQ is like really the way that you look for it. So so those are sort of the most important things about CTEP. Now, thought this was pretty interesting. So if you send somebody for a surgical referral and they're like, no, not a surgical candidate, inoperative, the standard of care is to get them a second surgical opinion. That is how effective surgical thromboendarterectomy for this is. Balloon angio we talked about. It's not quite as good, but it can be done. And riociguat, I just can't even remember what the hell this drug does. Maybe it's for CTEP. Maybe that's why I haven't included here. You know, Tom might know something that I don't, but I can't remember a damn thing about this drug. It's not first line, and I think that's the most important thing for us to cover here. Okay, so thromboendarterectomy, and then another evaluation for thromboendarterectomy if they're not a candidate the first time. Ashwin, you mentioned CGMP agonist. Do you have any idea in what context it's used? Because I can't. I'm having a brain fart right now.
Dr. Prister?
Hey,
Hi,
Jan,
Dr.
what's
Prister.
up?
Hi. Yeah, no, I mean, I looked it up. The jury is not first line. It's really considered after surgical failure. I mean, that's what the indications are. I mean, that's what the FDA indications are. If surgery or
Yeah, after
fails
failure
or
of like surgical
not
therapy, right?
considered a surgical candidate. But I want to ask you a question about pertaining to the endarterectomy. Do you know what the criteria are for the endarterectomy? I mean, how do they know if it will benefit the patient? I mean, are there certain
Honestly,
criteria in
I
terms
wish
of?
I could tell you. It's kind of outside my wheelhouse. I think a big part of it does depend on the size and how proximal it is in the pulmonary artery, right? So if you've got something that is like a big Goomba and it was either, I mean, saddles you don't have to worry about, right? Because saddles, they usually will just, they're hemodynamically unstable. They just take those things out at the time of the acute PE. But, you know, if they've got like a big, you know, like main pulmonary artery thrombus, that person's going to be a pretty good candidate for having the thing thromboendarterectomized. If they have like some more like small distal or more distal fibrotic clots, they might not actually just be able to get into that distal vasculature. So I'm positive that some of it is like an anatomic question, whether or not there are other things that may include or exclude the patient just on the basis of like how healthy they are. I'm not sure. But I mean, I can tell you that this is like not a particularly invasive thing. I mean, compared to some of the things that we can do. So I think in general, people should get it if we're able to. And if somebody tells you no, they're not a candidate, you're actually supposed to send them to another center just to make sure that they're not a candidate. So I don't know that there's a lot of data, Tom. So it might not be, it might be just a provider comfort thing rather than there's like a well-defined criteria for it. I'll look it up and I can email you guys
Oh, that's all right.
once I do
Yeah,
a little
that's
bit
okay.
of
No,
research on it, but I'm not sure just off the top of my head.
Right. Okay. Thanks.
No problem. So let me just write that down from endarterectomy and let's see, because I want to know for myself too. All right, Ashwin mentions lysodenafil increases nitric oxide dilates CGMP. So it's a vasodilator. Fair. Okay. Thank you, guys. All right. So let's get to the riociguat appears here too. Okay. I don't feel too far off base. I guess maybe riociguat is studied a little bit in CTEP. I'm just not really familiar with the literature. Okay. So let's talk about type 1. So this is the moment we've all been waiting for, right? We went through everything else. We went through the Heart disease, the lung disease, we spend a lot of time on CTEPH, and now we're on to this garbage bag of shit that, like, you know, all has a different pathophysiology, but does kind of fall into the final common pathway of the pulmonary arterioles are vasoconstricted, and so we're going to trial them on vasodilators. So what kind of stuff do we have in terms of options? So remember, when you finally put somebody into this category of, I've ruled out everything else, and I think that they've got pulmonary arterial or vasoconstriction. The next step is going to be, you're going to want to do that vasoreactivity testing. Also, obviously, if they have any heart failure, diurese the shit out of them, because you're going to do that pulmonary wedge, capillary wedge pressure measurement at the same time. So you diurese them, and then you do the right heart cath, you get the wedge, and you do the vasoreactivity testing then. If they're vasoreactive, then you can start them on nifedipine as first line. If they're not vasoreactive, there's like a whole smorgasbord of drugs, including sildenafil, prostaglandin therapy, bosentan, and riociguat. There are very extensive guidelines on which of these drugs to use, and do you use them in combination? For example, the combination of tadalafil and ambrisentan is now considered to be one of the sort of sexier first-line combos that we use in non-vasoreactive patients, or people who used to be vasoreactive but are no longer vasoreactive, because not everybody stays responsive to nifedipine long-term. So I don't know the combinations that we're supposed to use. There's a lot of guidelines on it, and this is a very pulmonary-specific thing. I just want to mention that, yes, we do have these drugs available, and you would consider using these drugs specifically in a person who has either failed nifedipine or was never a candidate for it in the first place because they weren't vasoreactive, and obviously also has that trash bag pulmonary hypertension, not heart disease, lung disease, or CTEPH. I'm going to take a second and contrast two liver things, because we talked about liver disease potentially playing a role here. So there are two conditions, right? There's portal pulmonary hypertension and hepatopulmonary syndrome, which sound very similar to each other, right? Only one of these things has pulmonary hypertension in the name, right? That's your portal pulmonary hypertension. That's because of poor metabolism of vasoactive peptides, or who knows, who cares, not important. And then there's also the hepatopulmonary syndrome, right? This is the one where you have increased flow, or rather dilation of the pulmonary capillaries. So you get increased flow and essentially almost like a right to left shunt. Sometimes it progresses to the point of AVMs. And the special thing with hepatopulmonary syndrome is, remember, they get that platypnea and orthodeoxia, right? Where they sit up and they get short of breath and they desat. That's because their lower lung zones that have these dilated AVM type capillaries, they're now being utilized more when these people are sitting forward. Both portal pulmonary hypertension and hepatopulmonary syndrome have similar physiologies. They, I think portal pulmonary hypertension has to do with vasoactive peptide metabolism. Hepatopulmonary syndrome probably has something to do with like some growth factor like VEGF or EGFR or God knows what. Who cares? The bottom line is, only one is pulmonary hypertension, and that's the one that has pulmonary hypertension. That's all I have to say. Okay, great. Okay, so we made it through alive, and there's no way I'm going to finish early. I thought I was going to like fly through this, and we like legit spent an hour talking about pulmonary hypertension. So I guess we're on to pleural effusions. Maybe I'll give you guys like, we'll finish 20 minutes early. I don't know. I'm not feeling super optimistic at this point. I clearly have no sense of time. Okay, so let's talk about pleural effusions. So here, these are your three most common causes, right? It's going to be heart failure, usually bilateral. Although you can get unilateral heart failure effusions, it's less common. We'll talk about pneumonia and pneumonic effusions, and of course, malignancy, very big, important topics. There are, let's see. There are obviously lots of other causes of pleural effusions. I know you guys have encountered so many of these before. The ones that I do want to cover with you guys, just because I think that they have a unique physiology, and I just want to remind you that these things exist. So these are mostly the transidates. There's less transidates than there are exudates, which is why I kind of want to focus on that. So Obviously, any state that's going to make your volume overloaded, like your heart failure, cirrhosis, etc., those things are going to give you transudative perfusions. There are a couple of things that are worth mentioning. There's hepatic hydrothorax, right? Remember that that's the one where you have some small defects in the diaphragm. And so when you have ascites, the ascites leaks through the defects and makes its way into the pleural space. This is more likely to present as a unilateral pleural effusion rather than a bilateral pleural effusion. I want to guess that it's on the right side, but don't take my word for it. Hepatic hydrothorax is a thing, and you fix it by fixing their ascites. Next thing is a urinal thorax, right? This is usually in your urology patient who has had some sort of cystoscopy, potentially with a cannulation of their ureter. When the ureters get cannulated, sometimes the ureter itself can get disrupted. They might actually rupture some area of the ureter and develop a urinal thorax that way. Peritoneal dialysis does the same thing, very similar in pathophys to hepatic hydrothorax, and the rest of the stuff is not really worth, delving into. I think you guys know as well as I do that transudates and exudates, that distinction is worthless and it does not matter. So let's move on to bigger and better things. This is Light's criteria. I don't know, remember it before you take the test, but it's not useful at all. Okay, let's get into some more useful stuff. So in some circumstances, even though a heart failure-based effusion is typically transudative, it can be exudative. And essentially what happens is you're looking at the concentration of the substances in the pleural fluid. If you aggressively diurese a patient like that, you're going to cause contraction of that pleural fluid without actually removing the solutes, right? So because of that, you can actually get a exudative appearing pleural effusion once you've adequately diuresed the patient. So in these circumstances, and you're not going to encounter them often, but a pleural pro-BNP level is actually pretty specific in terms of identifying a heart failure-based effusion after you've diuresed the patient. So, always save a little bit of fluid with the pleural effusion when you tap them, just in case you end up in a situation like this. The other thing to be aware of, remember that there is your serum pleural protein gradient. It works exactly the same way as a serum albumin ascites gradient for the identification of sort of transudative portal hypertension ascites versus more exudative infectious-y malignant ascites. It's the same kind of thing. So if you ever tap an effusion and you're kind of surprised by it, you're like, I thought it was going to be heart failure, but it's exudative. You could also check the serum pleural protein gradient, and that, again, it's the same concept as a SAG, which I won't bother covering with you guys. I think probably most of you guys are pretty familiar with that. Okay, useful tests, amylase, glucose, and ADA, right? And the reason they're useful is because they're not often terribly specific, but they can point you in a direction. So amylase is associated with cancer and gastrointestinal causes of an effusion. Low glucose is one of these three, right? Cancer, infection, and rheumatic effusions. And then elevated ADA is one of the highest yield tests that you can get, both for the pleural space and the ascites space, and also probably the CSF. Elevated adenosine deaminase is incredibly sensitive and specific for pleural TB. So it should be it's better than an AFB stain and cultures. And obviously interferon gamma release assay is good, but it doesn't tell you where their TB is. It doesn't tell you, well, is it just sort of quiescent latent TB, or do they straight up have tuberculomas in their pleural space, right? So an elevated ADA, adenosine deaminase, is an excellent test for this purpose. Okay, we spent some time talking about CTEPH. Well, PEs also cause pleural effusions, right? So CTA or PQ is possible, although presumably you're going to identify it without, you're not going to end up in the situation, right? So I probably don't have to worry about this. More high yield thing to know is how many times you need to thoracentesis these patients. So let's say you've got a pleural effusion, you're interested in it, you're a little concerned that it could maybe be cancer or TB or whatever. you should understand that cytology and AFB stains of this space are not good. So what you're supposed to do, the workflow is, you do a thoracentesis. If you don't get an answer, you actually should repeat the thora, because when you repeat the thora, you get about, I want to say about 15 to 17% more yield on that subsequent thora. If you've now done your first thora and your second thora on a patient, and they still have that pleural effusion and you're worried about it, it's not going away, they look sick, at this point, there's no point in doing additional thoras, because doing an additional thora gets you like 1% additional yield. It's like nothing. So if you didn't figure it out with the first two thoras, number 3 won't get you there. So at that point, the next step is going to be a pleural biopsy. If you want to talk about this, and let's see. Okay. So I do want to talk about pleural biopsies very briefly. Let's see. You know what? Actually, let's go to the asbestos picture, because that's probably the best place to talk about pleural biopsies. Here. Okay. So when you do a pleural biopsy, there's sort of 2 approaches that you can take, right? The first approach you can take is an interventional radiology biopsy, right? So that's just going to be an outside-in thing. And the second approach you can take is going to be surgery, right? Like sending them for a VATS, like the video-assisted thoracoscopy. Which one you choose depends on whether or not you have a biopsy target. So if you've got a patient with just a pleural effusion and nothing else, you can't do an interventional radiology biopsy on them. I mean, you can, but you shouldn't. And the reason that you shouldn't is because you're just doing a blind biopsy. So there's a pretty high chance that you're going to go in there and biopsy them, and you're just going to get like pleural tissue. You know, you might just get normal pleural tissue. So that's not useful. So if somebody has just a basic pleural effusion and nothing else, unfortunately, if you really want to diagnose them and this thing keeps on coming back, you're going to have to get a surgeon involved to actually physically, visually look at the visceral pleura, look at the lung, look at the parietal pleura, and see where is the abnormality, what do I need to take a piece out of? Because you might do a closed pleural biopsy with interventional radiology from the outside, and it might come back normal. Meanwhile, the tissue that was right next to the needle was cancer. You didn't pick it up because you couldn't see it, right? So that's kind of like the thought process behind how to approach pleural biopsies in these patients. Okay. So now that we're there, let's take a question break. Oh, I can't believe I included this question. I hate this question. I think I wrote it too. What's the matter with me? Okay, so we'll talk about paramnemonic effusions in a second. So I think let me work through this question live with you, and I don't know. I guess I got to figure out live why I structured it this way. So this question is giving you a patient who clearly has a paramnemonic effusion, right? He's coming in, he's here for pneumonia, he's got a fever, so 2 sats down, and when you CAT scan his chest, it shows left lower lobe consolidation, right? That's the pneumonia, and a loculated pleural effusion. Then you do a thoracentesis of it. And so the question is, which of the following tests is necessary in directing subsequent therapy? So it's kind of a trick question, and let me talk to you guys about like how to think through this, and then we're going to come back to it and talk about why this question that I made up as bullshit. So we'll come back to it in a second. Okay, so when you're dealing with an effusion next to a pneumonia, right, we call that a parapneumotic effusion. And the most critical question that you need to answer in a patient like that is that effusion infected or not? When it's infected, you call it complicated. And when it's not infected, you call it simple, right? So simple versus complicated parapneumotic effusion. If it's infected, if it's complicated, it's basically an abscess. Now, it might not be an empyema yet, but it will become one. So the point is if it's infected, you've got to drain the entire thing. You just got to get it out of their body. And how you do it doesn't matter as long as you drain the whole effusion. So if it's a simple effusion, if it's kind of like free-flowing, maybe you can get away with a thoracentesis. If it's not terribly free-flowing, then you're going to have to put in either like one of those big daddy chest tubes, or you could even do the little pigtails. Those are fine too. Like IR sometimes can put in a number of smaller catheters because they're more comfortable for the patient. So sometimes you can kind of drain it that way. Sometimes you'll have difficulty with draining these effusions, and so it's reasonable to put a little bit of TPA, tissue plasminogen activator, in there to try to break up some of that gunk and see if you can get better drainage. But if that doesn't work, then unfortunately, these patients will probably need surgery to just clean out that effusion. It's not common, but sometimes they need this. For your purposes, it's important to know that when you have an infected, a complicated parapneumotic effusion, you need to add anaerobic coverage onto your regimen, which you're not always going to have, you know, with standard pneumonia treatment. Anaerobes tend to invade the space, apparently. So who should get this? Like who should have, in whom should we look for a simple versus complicated parapneumotic effusion? Just get an x-ray. So have the patient lay on the side of the effusion and then measure the space between the ribs and the lung. So there's two things that you're going to be looking for on this picture. The first is how much space is there? If there's greater than a centimeter, right, about this much space, you really should tap that effusion. That means it's sizable enough where it potentially could make the patient sick. If it's smaller than a centimeter, it's probably not going to be safe to tap them anyway. So you don't do anything about very small effusions. But if it's a centimeter or bigger, you should tap it. The other thing is that you should very actively try to tap non-free-flowing effusions. So what's a good way for me to describe a non-free-flowing effusion? Let me see. Do I have any pictures of pleural effusions elsewhere? Did we look at anything together? I don't know. Okay, fine. This person maybe has some pleural effusion. Okay, so I forget that this person has ARDS for a second. Like, just join me in this magical thought process, right? So let's say clearly this person has obliteration of their left costophrenic margin on their X-ray. So what you should expect is if you laid them down on their left side, their X-ray should look like the one I just showed you. That effusion should go from their left costophrenic base to the lateral part of the lung. It should flow over there with gravity. This should layer. If you lay them on their side and you take a picture and the picture does not change, right? It looks exactly like this, where the fluid is sort of trapped in this space. Essentially, you've got a loculated pleural effusion. So the fact that it's loculated de facto makes it complicated. So if you have an effusion that doesn't flow freely, you have to be pretty aggressive at trying to scoop out as much of it as possible, unless it's like trace. I mean, if there's not really a whole lot of fluid there, then you don't need to do anything, right? Okay, so the X-ray dictates what you're going to do with parapneumotic effusions. This is it. So greater than 10 millimeters of pleural fluid or non-layering effusions should both be thoracentesis. And the purpose of the thoracentesis is to figure out, is the effusion simple or complicated? Is it not infected or is it infected? So these are the things that make it complicated, right? So loculations, you don't even have to tap a person to know that they've got a complicated pleural effusion. It's complicated because it's loculated. If it's acidic, if it's hypoglycemic, and obviously if there's a frank infection, right? If they're culture positive, it's a complicated parapneumotic effusion. And if you're seeing an empyema, if it's pus, you're done. So that's it for parapneumotic effusion. So let's go back to why I think this question that I wrote is bullshit, right? So it's giving you a pressure with parapneumotic effusion, and it's saying, which of the following tests is necessary in directing subsequent therapy? And I would argue with you, none, right? This person had a CT scan of their chest, and it showed a loculated pleural effusion. You know that it's complicated already. So you don't actually need any of these things to tell you that it's complicated. You know. So now you have your therapy kind of like laid out for you. Although the question is a little tricky because it says that you already did a thoracentesis. So which of the following tests is necessary and directed afterwards therapy? And remember, so this person has a loculated effusion. It's complicated, and the point of a complicated effusion is to get rid of it completely. So if you thoracentese someone, you better be sure you got the whole thing. So now I remember why I did this question, I think. I'm guessing. I'm just trying to read my own mind. The answer probably is chest x-ray, right? The rest of the stuff doesn't give you additional information. You know that it's complicated already. So really what you need to know is, did we fix it, right? Because if you get an x-ray and you didn't fix it, you didn't drain the whole thing, guess what? You're probably going to need to go back in there, do a chest tube, do another thora, or maybe send them for a VATS, depending on how gross it looks. LDH just tells you if it's a transitive or exudate, not helpful. Procalcitonin just tells you if they do or don't have pneumonia, not helpful because this person obviously does. Pleural protein, again, is more a Light's criteria thing, who cares? And pleural pH, yes, will confirm that this is a complicated parapneumotic effusion, but you don't need it because you've already got the loculations. So I take back what I said about myself. I was a little hard on myself. This is actually a good question. It's just, to work through it a little bit. Okay. And it's my question, right? So it's obviously awesome. Okay. So once you've gone through the process, if you've worked up this pleural effusion like crazy, sure, you can call it a viral exudate, but it's got to go away completely, right? If the effusion's not resolving, I don't know. I mean, I would really aggressively look for cancer. I would probably be calling the surgeon and saying, hey, this person has this chronic exudative pleural effusion. Please go in there and do a VATS. I mean, I'm concerned for this patient. Okay. Management of serial pleural effusions. Probably a lot of you guys have experience with this already, so I'm preaching to the choir here. So you have a few options, right? You've got serial thoracenteses. You could put in an indwelling catheter, or you could do a talc pleurodesis. So which one of these you choose depends on a couple of factors. Number one, what is the patient's long-term prognosis? Number two, how often is the effusion reaccumulating? And yeah, and I guess we'll talk about what their lung looks like in a second. So let's say that you've got a cancer patient. They're not going to live terribly long. They've got a bad prognosis, but and they have malignant pleural effusion, but it's not reaccumulating that often. You could probably just send that person for a serial thoracentesis. It's fine. I mean, going for a thora once every other week, it's not really a big deal, unless obviously it's very difficult for the patient. Then you might want to just get a catheter in them and send them home and use the catheter for palliation and for comfort. Before you do something that's more invasive than a thoracentesis, you want to make sure that the person is not going to get chemotherapy, because chemotherapy can make this problem better, right? So if somebody's got a pleural-based mass, they got a malignant effusion, but they're just starting chemo, even if they're not going to live very long, maybe they have a couple of months, the chemo may actually help the effusion from reaccumulating. So maybe give them a chemotherapy trial first before you sort of commit them to an indwelling catheter. Talc pleurodesis, I don't think we ever really do in these patients. You can consider it for somebody that is going to live for a long time, if they're going to live for a few years, and you can maybe, let's say that they do have a little bit of a pleural effusion, but you can thoracentese most of it out, and it reaccumulates pretty slowly, and they're going to live a long time. Those might be reasons why you could do a talc pleurodesis. we don't usually do pleurodesis for a few reasons. So the first reason is it's not logistically feasible. If your pleural effusion reaccumulates very rapidly, then the talc won't, you basically, you need to get really good apposition of the visceral and parietal pleura. And so if your pleural effusion is going to reaccumulate like super fast, like overnight, the talc won't do anything. It's not going to cause the visceral parietal pleura stick to each other because they're just going to separate right away as more pleural fluid accumulates. So that's one reason why why we don't do talc pleurodesis. Then the other reason is it's painful. So do you really want to put somebody through that? I mean, it sucks to get a pleurodesis. So you want to put somebody through that if they're only going to live for a few months. Probably not a great idea. You can do a pleurectomy, which is essentially a very aggressive pleurodesis. And also you could do a pleuroperitoneal shunt. These are very uncommon. I've never seen them done. And part of me is thinking, well, if they have cancer in their pleura and you shunt it to their peritoneum, are they going to get peritoneal carcinomatosis too? Anyway, we don't use these, so I've never had to answer that question. I've never even thought about it. So, but these are your options for malignant infusions. All right. I love this question. Okay, so I've got a couple of answers, some in public, some were directed to me. So we're in a couple of different places. So let's walk through this. Okay, so you've got a cancer patient, right? He's got stage 4 lung adeno, and he's coming in with a malignant pleural effusion, right? We were just talking about this. We thoracentesis him, and he feels better. When you do a follow-up chest radiograph, you actually don't get re-expansion of the right lung. You have air that replaces the removed pleural fluid. Then he comes back to the emergency department with increasing dyspnea. He's not feeling good. He's got a big pleural effusion, and then you get a repeat chest radiograph, and you've got a large right-sided effusion with loculations. It's not that surprising that this happened, right? Considering that he's got a malignant pleural effusion. So now it's asking you, how do you manage this person appropriately? So a couple of things. First thing is, look at what happened to him after he got his first thoracentesis, right? You did the thora, and his right lung didn't re-expand completely. Matter of fact, air replaced the removed fluid. This happened because his lung was not able to re-expand. He has a condition called trapped lung. And you can get trapped lung from a number of things, but essentially what's happened with him is that his visceral pleura is cancerous and it's fibrosed, and it's containing the lung in like a visceral pleural capsule. So it doesn't matter how much you drain of that pleural space, the lung physically can't expand because it's trapped, right? And so here you've got that post-thoracentesis chest CT showing you what a post-thoracentesis trapped lung might look like. They're saying, what do you do with this person? So let's go through it. In terms of pleurodesis, it's not going to work for this guy, right? Because if you want to pleurodese him, you need to have good apposition of the visceral parietal pleura. You're not going to get that. right? The visceral and parietal pleura are separated from each other. You could thoracentesis them again, I guess, but it's just going to keep on happening, right? So I think doing a repeat thora is not the wrong answer, but it's just not a more semi-permanent solution. So now you're left with B and D, which were actually the two answers that I got. People were like a little bit conflicted about them. So I think that both an indwelling pleural catheter, just for sort of chronic management of the effusion, and surgical decortication are potentially reasonable options. So what is surgical decortication? Basically, they're going to go in there and they're going to scrape off the visceral pleura from the lung. It's a pretty invasive, aggressive procedure, but you could do it in a person that has a trapped lung. I think the main reason that I would probably go with a pleural catheter for this guy is that he's got advanced cancer, right? He's stage 4 lung adenoma. So I'm not an oncologist, right? So I don't really know what his long-term prognosis is, but it's stage 4, so it's probably not very good. We're probably dealing with a months-long illness. And so because of that, putting him through a surgical decortication, like clavicle pleurodesis, it's like a big thing, is going to need anesthesia. It's problematic. So this person is probably going to be more of like a palliation approach type of case. So probably best way to approach him is an indwelling pleural catheter. Okay, so you know what? I am a man of my word. That's it. That's all I got for today. So there are some things. You know what? Before we go on, let me answer. So Sherry writes, do you think it's important to know the difference between a trapped lung versus an entrapped lung? Honestly, Sherry, I have no idea. I didn't realize that those were two separate things. If you know the difference, I would love for you to cover that with us, because I don't know myself. If not, then I'm very happy to do what I've.
The only way that I figured it out was I was just Googling really quickly, trapped lung based on what you were talking about, and it auto-filled in Google trapped lung versus entrapped lung. So that's the only way. I just found out myself 60 seconds ago. But it put me into a panic. I'm like, oh no, do I need to know this now too?
Yeah, I don't think so, but I'm going to put this on my list of things to look up. I'll look after we're done tonight. I'll do a little bit of research on it, and I'll email Teresa, and I'll ask her to kind of shuttle the information along to you guys. If there's anything that's worthwhile. I've never heard that there was difference, but I'm not a pulmonologist, so I'm pretty basic as far as that's concerned. So I'll look it up. So let me just add that to my notes. Trapped versus entrapped. Okay, yeah, I'll get back to you guys with it. I'm not sure. Okay, so we're done. I do want to give you guys a very brief overview of things that I just decided not to cover because I didn't feel like they were going to be high yield. And honestly, there's just not a lot of content. This stuff just appeared in Mixapp, and I wanted to put it on your radar, but it's unlikely that that there's going to be a whole lot of questions that are asked about the stuff on the board. It's just that it doesn't come up often. So sleep medicine. This was really just where and when to get polysomnography. That chapter kind of talked mostly about sleep hygiene. This stuff doesn't really appear on the boards that often. There was a little bit of stuff on sleep medicine that distinguished between obstructive and central sleep apnea versus obesity hypoventilation, right? So I think big things here are just pathophys, right? So obstructive sleep apnea is because you've got a big neck and a lot of pressure on your trachea, versus central, where you just don't breathe. They're both pretty much treated the same way. You use nocturnal positive pressure ventilation, right? CPAP or bi-level positive airway pressure BiPAP. Obesity hypoventilation syndrome is also very similar, treated in a similar way, right? You use nocturnal, I guess you could use nocturnal CPAP or BiPAP, but the problem with obesity hypoventilation syndrome is they always hypoventilate, so there's not really a good way to approach this problem. Probably weight loss, bariatric surgery. There's not a whole lot else to add there. There's a brief stuff on mountain sickness and the pathophysiology of it. I figured it's not worthwhile to cover it. Just remember that Diamox, acetazolamide is in their pocket to deal with that. There's an entity known as high altitude cerebral and pulmonary edema, and the treatment for that is to lower your altitude. You could use steroids, I think, for it, but you should just take them out of altitude. I mean, it's kind of silly. And then last thing, this part I do think is important, so I will cover it with a little bit more detail for you, is air travel in the context of pulmonary disease, because I'm sure a lot of you guys get asked this question fairly frequently. So somebody comes to you and they're saying, hey, I've got some lung problems, can I get into the air? There's sort of two things to consider. One is their oxygenation, and two, the special circumstance with the barometric pressure issue that we talked about with, let's see, where the hell was it? With pneumothoraces, right? So if somebody has a recent pneumothorax, I probably wouldn't put them on a plane right away, right? Their pneumothorax has to really heal up and be completely gone. If they had a pneumothorax 3 days ago and now their X-ray looks fine, I'm probably not going to tell them to get in a plane right now. I'd be like, man, maybe give it a few more days or a couple weeks. I don't really know that there's like a good guideline in terms of time, but pneumothoraces are a big deal, and I mean, certainly you don't want them to get a pneumothorax when they go on the plane, because they're on the plane, right? No one's going to needle decompress them up there; they're going to die. So I probably don't send them on a plane right away. It's a bad idea. The sort of more common issue is for people who require oxygen. So, or for people with lung disease. So let's say you've got a COPD, but they're not particularly hypoxic. If somebody has COPD or interstitial lung disease, but their oxygen saturation is fine, it's like 99%, they can go on a plane. There's no special considerations. Get them up there. If they're a little bit borderline, like let's say their oxygen saturation is like 90 to 92%, keep in mind that when they go to altitude, the oxygen tension is going to drop when they're at altitude. So because the oxygen tension drops, you may actually want to send them on the plane with a little bit of supplemental oxygen so that they don't start getting symptomatic and hypoxic and short of breath when they're in the air. And of course, same thing goes for people who are already on oxygen. You might say, okay, you're going to go to altitude, maybe just add a few more liters onto your O2 while you're up there. If they've got a pulse oximeter with them, they can titrate it to their pulse oximeter. But my main point is when somebody's at altitude, the oxygen tension goes down. And so if they're predisposed to having hypoxia, that problem will get worse when they go to altitude. So give them some supplemental oxygen if they're like on the borderline, or obviously more if they're already on. Okay, so that's it. I don't have any other slides. I don't have any other questions. We pause. Anybody have any questions that I could address? Okay, great. Guys, thanks for listening to me for the last 6 hours. You're awesome. Thanks for being troopers. I had a lot of fun doing this with you. I really appreciate you guys participating with me in this. Good luck on your boards. I'm going to be recertifying with you in October, so I am not looking forward to it myself. But yeah, good luck to you.